Welcome to Module 7. In this module, we will cover the importance of data and the roles of medical records in trauma quality improvement programs. The information in this presentation is largely based on the guidelines for trauma quality improvement programs by the World Health Organization. As with previous modules, the website for this document can be found on your screen. The core learning objectives for this module are to provide a basic understanding of the importance of adequate data collection and how to implement trauma registries. All of the activities of QI rely on adequate data. In many circumstances, there is a need to address improvements in data collection and usage to better assure timely, reliable, and adequate data on which to base QI activities. This may imply better recording of data at the time of the patient presentation, better handling and availability of data from standard medical record systems. In some cases, the establishment of a formal trauma registry, which can be done in an affordable, sustainable, and simple fashion. Part of instituting or improving QI activities involves improving the documentation of trauma care in the medical records, especially in the early phases of care. Such improved documentation would be both for day-to-day management and for aiding QI monitoring and management of care in the longer term. An example of improved documentation would be recording more extensive and detailed information at the time of service provision, especially for cases in which the patient expires soon after arrival at the hospital. Any such efforts to improve record keeping need to be seen as beneficial by care providers and should therefore not be unduly cumbersome or time-consuming. QI must be supported by appropriate infrastructure and reliable methods of data collection. The goal in data collection and analysis is to obtain consistently valid and objective information identifying opportunities for improvement. Results of analysis must define corrective strategies. There is a need for functional and sufficiently detailed medical record systems, as most preventative death panel reviews are retrospective. In many locations, death panel review data has been held back by lack of adequate documentation. This is often the result of minimal recording or information at the time of service provision, especially for cases which expire soon after arrival at the hospital, cases on which the PI process should specifically focus. On your screen, you will see a SAMPR Performance Improvement Tracking Form. Please take a moment to review. Advanced QI methods such as tracking of statistical methods require more advanced medical record systems. In many cases, this implies a trauma registry. A trauma registry is built upon but not distinct from the more general medical record system. Please take a moment to identify what kind of information trauma registries may collect to be useful. The American College of Surgeons Resources for Optimal Care of the Injured Patient defines a trauma registry as a disease-specific collection composed of a file of uniform data elements that describe the injury event, demographics, pre-hospital information, diagnosis, care, outcomes, and cost of treatment of injured patients. Please take a few moments to think about what distinguishes a trauma registry from a general medical record system. Let's talk about the trauma registries versus the general medical record system. Trauma registries allow for ease of analysis and the ability to track specific data, such as complications or process of care measures. The ability to adjust for severity of injury distinguishes the trauma registry from the general medical record system. Trauma registries differ at different facilities as to inclusion and exclusion criteria, data elements collected, and the software used. Most use a fairly standard inclusion criteria as to diagnosis, including data on most patients with ICD codes ranging from 800 to 959.9. Depending on the specific registry, a level of severity is often used, with patients being included in the registry if they are admitted to the hospital at all, admitted more than 24 hours, or admitted for more than 3 days. Generally, any trauma death at the facility is also included. Some registries exclude specific ICD codes, such as those representing late effects of injury, isolated hip fractures, or foreign body aspiration. Data recorded in registries include several variables from each of the following categories: demographics, mechanism of injury, related location and circumstances, pre-hospital information, vital signs both pre-hospital and at an emergency department arrival, diagnosis, level of severity of injury, whether by GCS, ISS, RTS, TRIS, or another score, procedures performed including operations, outcome including length of stay, complications, and data on costs and resource utilization. The American College of Surgeons National Trauma Data Bank collects data on 76 variables. Many hospital-based trauma registries collect data on more. Various proprietary registry software packages are available. Many can be run either on standalone PCs or on hospital networks. However, it is important to note that many successful registries have been created using low-cost or even free, simple-to-use software such as EPI Information. It should be noted that networks of clinics, smaller hospitals, and medium-sized hospitals often play a substantial role in region-wide trauma care, as they are often the first level of referral to higher facilities. In some cases, their role interacts and overlaps with pre-hospital care in the area. Region-wide trauma QA activities will, of necessity, incorporate cases handled at numerous facilities. In more advanced systems, this can be done through the establishment of region-wide trauma registries and more formal region-wide trauma QI work. More generally, however, region-wide preventable death panel review could serve as a means to identify problems in the process of trauma care at smaller facilities. Moreover, constructing the panels to include care providers from these facilities will help create political will to institute the necessary corrective action. There is growing experience with trauma registries in low and middle income countries. In Uganda, a 19-item registry was established which permitted severity adjusting using a locally developed Kampala trauma score. This registry was created using the freely available program EpiInfo. In Zaria, Nigeria, one research study reported on the institution of a trauma registry of injured children that was set up, which derived data from a single sheet 10-item form. It is notable that due to the resource restrictions, this has been maintained in paper format and not computerized. Nonetheless, it has been useful for identifying issues that were then targeted to improve care of injured children and has resulted in reorganization of pediatric trauma care at their facility. In Pakistan, an extensive registry was established which utilized severity adjustment using Trauma and Injury Severity Score, or TRIS. This approach proved very useful for identification of problems to target the local QI process. In Khon Kaen, Thailand, the QI program relied extensively on the trauma registry created at the institution. In summary, all QI techniques rely on adequate data to obtain consistently valid and objective information identifying opportunities for improvement. A component of instituting or improving QI activities may involve improving the adequacy of documentation of trauma care in the medical records, especially in the early phases of care. Such improved documentation would be both for day-to-day management and for aiding QI monitoring and management of care in the longer term. Any efforts to improve record keeping need to be seen as beneficial by care providers and should therefore not be unduly cumbersome or time-consuming.